It is a pleasure to be able to join the FSHD Society and its community today. The topic that I have, and I'll speak for about, I think, 15, 20 minutes, and then we'll open it up for discussion, is a topic that is very much inspired by what has been going on from a public health standpoint, really all over the world, in the United States and beyond. And it's about sort of, spending more time at home and optimizing the home experience for safety and accessibility. As I talk about, a big piece of this is also fitness. So sort of the final title that I chose for today was basically, fitness, and exercise, home accessibility, and then how all of that comes together. If you're able to be physically active and you are able to be in an environment that is optimized for function, I think that's the way to optimize safety as well. And in these times of, social distancing and, up until recently, these stay-at-home orders, I think this is more and more relevant. I'm at the university, I'll just speak a little bit about my background. So I'm at the University of Kansas. I'm a neuromuscular physician. As part of my role is that I see patients at the Muscular Dystrophy Association care centers or clinics, and work with patients with hereditary, muscle diseases, including FSHD, and hereditary, mitochondrial diseases and, neuropathies as well. What's interesting in thinking about this topic and preparing about this topic, which was designed to, to just be relevant to what is going on, right now in our communities, and all of us really. What's interesting is that, in residency, as a neurology resident, you don't really learn as much about, or at least, it didn't come up as, home accessibility, home safety, and in fellowship less so. But this is something that's extremely important when working with patients at the FDA care center. So this was, a very important and neat topic for me to review and to talk about today. So let's first talk about exercise and physical activity as sort of the first pillar of working towards, being safest and optimized at home. So, if we look at what is known in the scientific literature about exercise and physical activity broadly, not just in FSH, we have very, very strong evidence that, with regards to all-cause mortality, it is reduced, and it's reduced across the board. So there's less mortality in women, men, the young, the old, and it can be, structured, regimented, planned, repetitive physical, exercise, or it can actually just be increased physical activity as meant by increased energy expenditure as part of your day. Very important is that this all-cause mortality benefit is dose dependent. So the more you do, the greater the benefit, but the benefit starts even with low doses, which is very encouraging for all of us. And then there's a plateau. So you don't need to be a marathon athlete to benefit from that. With coronary disease, with heart attacks and cardiac death, there's reduced incidence. And then, for heart disease, if you are found to have it, exercise helps reduce further events and disease progression. Hypertension, there's reduced incidence. There may be a modest protective effect of exercise in cancer incidence. With obesity, it can help prevent it. It can help treat it. With bone thinning and bone injury and fractures, their exercise can help prevent further bone fractures. And then last but not least, in fact, I think extremely important, is that exercise has a very positive effect in the psychological sphere. And by that, there can be improved sleep, reduced stress and anxiety, as well as reduced depression risk. Okay, so now, what I want to do is pivot and talk about, FSHD and some of the major studies of exercise, in this subset of neuromuscular patients. So it's essentially in chronological order. Let me see here. Okay, so we have a study from the journal Neurology in 2004, a randomized controlled trial with a study size of 65, which may seem small, but for a relatively rare condition like FSHD, I would say that's a very hard study to do, hard to recruit. So quite, a sizable study, 52 weeks, and it was basically strength training of two muscle groups. Elbow flexion, and then foot flexion or dorsiflexion with added albuterol. This is sort of the famous albuterol study versus no training at all, versus no training. And basically, this was essentially a negative study, and for this reason, that would be the reason that albuterol is not recommended for its potential anabolic effects on muscle. In 2005, another study in neurology. This was a shorter study, 12 weeks, and this is sort of the low intensity aerobic exercise, which we'll talk about more during the seminar today, which basically showed that 12 weeks of aerobic exercise basically improved aerobic function, so O2 uptake and workload, with no evidence of muscle damage, which, in conditions like FSHD, where, there is a tendency over time, there is, muscle breakdown and muscle replacement, you worry about intense exercise potentially accelerating muscle damage. But in this study, there was no evidence of muscle damage, and it was felt that this was a safe method to increase aerobic exercise. Let's see. So for this study in 2014, this was a study that looked at chronic fatigue being known as one of the manifestations of FSHD, one of the things that can happen. So this was a randomized controlled trial, which is the gold standard, and a size, there were 57 patients, which is, again, pretty sizable for what we're discussing. And the interventions were aerobic exercise or a form of talk therapy, which is known as CBT, or cognitive behavioral therapy, or usual care. And the study was done, there was a 16-week intervention, so 16 weeks of exercise or cognitive behavioral therapy, and then there were another 12 weeks of follow-up. So in both groups, aerobic exercise and CBT, there was less fatigue. But CBT, interestingly, the cognitive behavioral therapy, the talk therapy, had broader effects than aerobic exercise, with a positive impact on both sleep quality and sleep participation, along with the fatigue benefits that I just described. So the VOET study, 2014, there was sort of like a piggyback trial. So it's the Janssen trial, which you see here on your screen, which was published 2 weeks later. So what they did in the Janssen sort of piggyback study is that in this randomized controlled study of talk therapy and aerobic exercise, they also did high resolution MRI to look at the fat content of muscle. And the thinking there is that you want to test to see if certain interventions can decelerate or slow down the fatty replacement of muscle in patients with dystrophy, with FSHD in this case. So what was found, this was 31 patients. It wasn't all the patients in the previous study. It was 31. They used a very high resolution MRI, so a 3 Tesla MRI. And there was evidence of slowed fatty infiltration in FSHD patients that were doing either aerobic exercise or CBT or the talk therapy compared with the usual care. The Anderson study In 2015, again in neurology, this is sort of another, moderate size study, but large again for FSHD. 12 weeks of an exercise group and then an exercise group plus protein versus no exercise. So again, exercise plus protein supplements, and no exercise. And basically, patients did better after 12 weeks with improved fitness, workload, and speed, but the protein supplement added no additional benefit. And then the Bangolet study, a study from France, which is distinguished because it's a longer term study. This went for 6 months or 24 weeks, but on the other hand, it was a small study, only 16 patients, that basically rode a bicycle 3 times a week, at home for 6 months, that showed improvement of aerobic capacity. So basically greater capacity of the body to extract oxygen, from the air. But also, interestingly, they did a functional test, basically to look at performance in the community or to try to evaluate or, approximate a function in the community with a 6-minute walk test, which is basically where you walk for 6 minutes. And what they found that, there was increased aerobic capacity. You could walk for a longer distance after this exercise program compared to the, usual care group. And there was decreased fatigue. And then also they did muscle biopsies before and after the study. And there was, again, no evidence of muscle injury that you may be able to see on a muscle biopsy under the microscope. So that's also encouraging because it would suggest that, exercise, light to moderate exercise does not pose a risk to the muscle of patients with FSHD. Okay, so then, the next question is, how do we apply this information? We have this data, this scientific data. So how do we apply this information in FSHD? So, the studies, of course, are not going to be perfect. They can't be. There are limitations, certainly. Some of them, an important limitation is that there's no long-term follow-up. It'd be very hard to do. So you may have an improvement in 12 weeks or 6 months, but does that mean that you're going to have an improvement? Are these patients going to continue to be better at 12 months or 3 years or 5 years? And then also, another major limitation is that what you're looking at oftentimes, not always, is physiological variables such as aerobic exercise, but does that really translate in improved quality of life and improved function in the community? That's also, that's a question. But, on the other hand, we do have some pillars of knowledge, based on the scientific literature on science. So basically, I would say that there's a backdrop of overwhelming evidence of benefit of exercise in the general population. We have no proof of harm in patients with FSHD, and then disease-specific studies that indicate, a couple of different things that we've talked about. So there's increased aerobic capacity, reduced fatigue, slowed fatty replacement of muscle, and there's also some evidence of improved function. So overall, some very, encouraging information. And I think overall, the case for exercise in FSHD is very robust. So strongly recommended, Okay, so what types of exercise? Before we go further here, I would mention that, just like many other neuromuscular diseases, there's a great spectrum of manifestations and disease, state and phase. So, each program should be individualized based on age and the actual manifestations. But what is the menu of options? So number one, aerobic exercise, and this includes walking, swimming, a stationary bike, propelling a wheelchair can also be a form of aerobic exercise or housework, and sort of a number that's sort of generally recommended is 150 minutes per week at 60 to 70% of the maximum heart rate, which is sort of in the light in aerobic exercise, that's sort of not it's sort of in the light degree. Strength exercise, which can consist of lifting small weights or pulling elastic bands. This would be recommended 2 to 3 times a week, and this would be timed separate from those 150 minutes or 2.5 hours. And it would be light to moderate weight. Heavy weights not advised in patients with muscular dystrophy, and over time would focus on increasing the number of repetitions over focusing on building weight. And then, of course, stretching is the sort of the third leg of of the exercise options. And this would be gentle stretching exercises, gentle yoga, Tai Chi, with sustained repetitions of 30 to 60 seconds and no bouncing. So what are some tips for increasing physical activity? And this is really true for everyone. So, if there is pre-existing medical illness such as heart disease, diabetes, kidney disease, liver disease, or others, may need then would need a formal screen with your primary care provider. Also, if there's concerning symptoms like chest discomfort, shortness of breath at rest, or persistent pain, same thing, a formal screen. If you are following with a neurologist or a physical therapist or occupational therapist, this would also be something to discuss. As you start a program or wish to continue a program. Simple in my mind, in my view, is good. A gym in general, pandemic notwithstanding, but a gym is not necessary. I think a wonderful way to incorporate, and also efficient way to incorporate physical activity in day-to-day life is basically incorporating activity in daily life. So examples of that would be walking the dog a few times a day, choosing the stairs over the elevator if that's a safe option, walking to work if that's a safe option, and public transport over other forms of transport, of course, with a big asterisk right now, given the very important continued need for physical distancing and social distancing. Ideas to help with motivation, a step counter may help, and those are really kind of universally available since most smartphones have them. And exercising with friends or an exercise group can also boost motivation and help with participation, again with an asterisk for the duration of the COVID pandemic. These are some of my personal suggestions. Avoid the hottest times of the day, especially now that we're entering in the summer season. Avoid the sunniest times of the day as well. If you are going later in the day or in the evening because of your work schedule, reflective clothing items can be helpful, and this is something actually that I have, that I use sometimes later in the day. And then in terms of like some big picture advice that I think is just extremely important is basically start low, go slow. There's no rush. And it's much easier to sort of prevent injury than to recover from injury. And this is true, even for like high performance athletes. It's easier to prevent an injury than to recover from it. Remember, it's dose dependent, and even small amounts can have a benefit. So be encouraged with every little amount of physical activity that you can do. Not only it's good for you, but it's likely to make you feel better. And I think sort of a sports analogy is that it's not a marathon, physical exercise. Well, I'm sorry, it's not a sprint. It's more like a marathon. You want to pace yourself, pace yourself, and don't burn out. Okay, so, physical exercise is very important, but what about home accessibility and accessibility or usability? What are the things that you can do at home to sort of function at your best? So you can talk to your physical therapist and occupational therapist at the MDA Care Center or anywhere else that you're seeing. what they can offer is a home safety evaluation, and this can be done also remotely. You can send pictures of your bathroom or your kitchen, or other, or the exit to your home, and these can be, you can bring them to a visit, and these can be evaluated, and you can get suggestions for home safety. I know that at our MDA Care Center, there is a role for us for advocacy, for securing any resources for any necessary home modifications. So when it comes to home modifications, an area of interest of great interest is the bathroom for accessibility and safety. This is because it's used a lot, and also because it can be a place with some risks. So this is actually a picture from the most recently added inpatient units at the University of Kansas. So it's basically, it's 2 years old, a little more than 2 years old. And I sort of looked at it one day, and I realized just how much thought had gone into designing it, and how much we can all learn by just kind of like breaking down the design. So you'll notice here, the green arrow, that it's spacious and the entrance is wide. So to make it easier to get in and to make it easier to access with a wheelchair. You'll also notice that there's a sliding door and at least no doorknob, because patients that may have distal weakness, not for FSHD, that is not the most common location for weakness, but if there is distal weakness, doorknobs can be particularly hard. And let's look at some other design features. So there's a handrail in the shower, which can be extremely helpful in this environment, a slippery environment, an environment where you sometimes have to close your eyes. And there's also, trip hazards as well if you're sort of trying to go over a little bit, going into the bathtub if you have a bathtub. So handrails, also adjustable handrails that can come up and down on either side of the commode. A shower chair here, which is for some patients, it may be a safer way to bathe than to stand. And notice that on the bottom here, there's these very neat rubber chair caps that make it much harder for the chair to slide, or a bench, or whatever the case may be. There's an elevated handheld shower head, which keeps the tube, further away from the feet, so it's less of a tripping hazard. The access to the shower, there's no ledge, so it's also a roll-in shower, which can be extremely, extremely helpful and convenient. There's a shower drain, so that's where the water will go. You'll notice here that there's no cabinets under the sink, and that makes it easier for patients in wheelchairs to use the sink. And then there's also, this may not be an option at home, but there's also an alert cord. If there's a fall, you can call for help. And then in some patients that have proximal weakness, with myopathies, certainly a concern. Standing from a low position can be harder. So an elevated toilet seat can be helpful. So other areas of the home are the kitchen. Now with the pandemic, more stay at home, more time in the kitchen. So general strategies are relocating often used items such as dishes and glasses. You can install pull-out shelving in cupboards that makes it easier to reach items. The dishwasher can sometimes be harder to access because you have to pull it all the way down, and then you have to reach low to get a tray. So there are such things as drawer dishwashers, and sometimes they can be customized. So it can be one drawer and it can be higher up so that it's easier to pull, easier to load and unload. There is such thing as a drawer microwave, and a side-by-side refrigerator, which is recommended for patients that may use a wheelchair, so that you can access both the fridge and the freezer, at sort of eye level. And then, with the washer and dryer, a patient mentioned to me recently that she relocated them from the basement to sort of avoid what can be sometimes a treacherous staircase, like a more treacherous even staircase than you have for going upstairs in a lot of homes. So more things about home safety and home accessibility and home usability. So for doorways, wider doors can be helpful. A sloped walkway and no steps or fewer steps. And as we discussed earlier, if doorknobs are a problem, these can be swapped for lever-style handles or sliding doors. For fixtures, you can consider smart home controls that now have become so much more available and more affordable. For hard-to-reach lights or fans or the thermostat. And then for stairways, you may benefit from handrails on both sides. And finally, I have some suggestions for fall prevention, at the home and for safety. So basically tripping hazards. So small rugs, extension cords crossing the floor. I would remove them. Certainly going to the bathroom at night when people are tired, groggy. This is a high risk time. So if you have a cane or a walker, make sure that it's accessible. I would keep a light on at night so it's easier to find your way to the bathroom, and you don't have to walk or take a few steps in the dark until you can turn on the light. Footwear, along with sort of home safety stuff, no high heels if there's ankle instability or, lower extremity weakness. No shoes where you can slip and slide like sandals, avoid slippers. And then hydration is a good way to reduce dizziness, and dizziness can predispose to falls. And then, bathroom use, be particularly careful when walking to the bathroom. And as I mentioned, this is a high risk period for falls. And to sort of kind of bring things back to where we started, in terms of fall prevention, exercise can be helpful. Try to, optimize your muscle strength. And also if, balance is an issue, you can also, along with aerobic exercise, a degree of strength exercise and stretching, you can maybe incorporate balance exercises and make that a bigger focus of your exercise regimen. Those are my my slides for today. And thank you. And open for questions.
Great, thank you so much. So yes, everybody, you can post questions in the Q&A tab, and I see we have one there already from Ray. He was noting the slide that you showed of the bathroom. He was wondering how one transfers from a wheelchair to the shower in that bathroom.
Yeah, so that's I mean, I don't know the specifics of the situation, and transfers are unavoidably a higher risk maneuver. If there's a better design that the audience member had in mind, certainly. So I can't comment further on specifics, but if there are questions, I would refer them to your local clinic or occupational therapist. But I agree, transfers, of course, are the unstable part, the hard part. You may need a caregiver, you may need something else.
Mm-hmm. Great, thank you. Let's see, a question I've had myself, I'm wondering if on floors, whether wall-to-wall carpeting versus bare floors, different, traction issues, but also obviously if you fall on carpeting, you're probably less likely to injure yourself than if you fell on a hard floor, but what are the trade-offs there? And
yeah, that's a really good question. I would imagine there are trade-offs. Wall-to-wall, first of all, the thing that I can think of is that wall-to-wall carpeting is probably safer than carpets that have ledges, like throw rugs. So number one. Number two, rugs, wall-to-wall carpeting would be softer if there's a fall, absolutely. But if you find that there is a degree of foot drop and you're not using AFOs, for example, and at home you may not be using ankle foot orthoses. So if you find that your toes catch a lot and that you're tripping and that there's a risk of falling because of toe catching on the carpet, then I would say that is a downside. So I think it goes both ways, but certainly, rugs, small rugs that can, the things that are clear in my mind is that rugs that can bend, that can fold, those are the ones that are, a real issue.
mm-hmm. Okay, thank you. Question here, is stretching bad for people with FSHD? So I guess it's a question of flexibility because people can lose flexibility.
That's a good question. And I think I'm not aware of like any specific study. I review the studies. I'm not aware that stretching has been shown to be bad for patients with FSHD. I think that what can be in theory harmful is strength training with heavy weights, because that could damage the muscle fibers. But stretching that is modest, that is slow paced, that is not overly aggressive, no bouncing, I think can be helpful. Now, is it good to be as flexible as possible? I don't know that would be true. You don't need, I would say if you can work on flexibility a little bit and sort of maintain flexibility, that's good, but you don't need to be at high performance levels of flexibility. And I don't think that it can hurt if you work on flexibility modestly.
Mm-hmm. Okay. Question here, how much weight is too much to exercise with? So you caution against exercising with heavy weights. If this person said if he can do 10 easy repetitions, is that an okay weight to use?
Yeah. So again, this is what I'll share is an extrapolation based on, the studies that are available. I think if you fatigue in 7 reps or so, that's considered, high intensity strength training to like build muscle. And I think that is probably too intense. My assessment, and this is an opinion, is that you want to do more reps than that. So like 10, 12, 14, but certainly, 7 is too few. If you basically go to exhaustion at 7, I would say that's too intense. So 10, 12, 14 seem like a safer and also a more goal appropriate amount of reps to do per round to failure.
Okay, great. Here's a question referring back to the discussion about stretching. Said this person says, my neurologist has warned about overstretching that can lead to micro tears of muscle. Could you comment on that?
Yeah, I'm not, I would say light to moderate. Again, nothing extreme. I'm not aware of, any specific studies on harmful stretching. So I would say when in doubt, light to moderate. And yeah, that's, I think that's the most I can say.
Okay. There's a comment here about, can you discuss some of the topics for people who are full-time chair users? So I suppose walking, running, those things are not an option. What are other ways a full-time chair user can use to stay fit?
Absolutely. Yeah, so in many neuromuscular conditions, there's a very broad spectrum of where people are at. And the exercise regimen has to be individualized. So in folks that are using a chair, I think a really nice way, and it may not be for everybody because some people like it or not, but I think water exercises like aqua therapy, if available, can be a really nice way to, and it should be supervised as well, because if you have significant weakness, it's important to have some support when you're in the pool because it can be dangerous. So I think, water therapy would be good for patients that are in a chair. Another thing would be like an arm treadmill, like if available. That might be, another option. Exercises, using the arms, or if you're in a chair, you can sort of stretch the knee. So basically knee extension, and do exercises that way. And yeah, those are some of my, so basically for aerobic exercise, you could, if you have access to it, you can do a hand treadmill, swimming, and then also light weight training with the joints where you have the ability to do that.
Okay, great, thank you. Cool. Question about cognitive behavioral therapy. Can you expand on how that works for FSHD specifically, and how would you have access to it? Who provides cognitive behavioral therapy?
Yeah, so great. So thank you for all the questions and all the engagement. These are all wonderful questions, and I'll try my best to answer them. So cognitive behavioral therapy is basically, it's basically like a form of talk therapy. It's a methodology. And what it aims to do is that it aims to address any cognitive misperceptions, and to help that are causing problems with function, and sort of dealing with situations and coping skills, and aims to help develop insight about some sort of adaptive strategies that may not be ideal, so that you can develop more adaptive coping mechanisms. So it's basically like a talking cure in a sense. So how might that work? So I think the idea there would be that in patients with depression, in patients with anxiety, in patients that have struggled to optimize, understandably, it is a struggle and it is very hard. So maybe a boost in ideas about sort of coping mechanisms for the disease, social integration, if there is depression, managing depression, that all these things can then make it easier to be more active, to be more integrated in the community, to be more functional, and thus, as a result, a sort of like a secondary benefit of greater mental health and social engagement, you can also have better physiologic outcomes and muscle outcomes. So I think my understanding is that, and of course with fatigue, that study with the CBT, one of the outcomes was fatigue. So fatigue can have many causes, and certainly CBT could begin to address some of those causes of perceived fatigue.
Great, thank you. It's a comment from Colette, who's saying sometimes it's hard to incorporate 3 times a week with normal activity without suffering from considerable fatigue and sometimes pain. Any suggestions for finding a balance?
Let's see, is that a written, can you repeat the question, please?
The question is, sometimes it's hard to incorporate exercise 3 times a week with normal activity without suffering from considerable fatigue and sometimes pain.
Yes.
How do you find a balance?
So, I think your body's talking to you. If you have pain after exercise, that, in my mind, in my perspective, is something that needs to be heeded. Your body is telling you that it's maybe too much. So you have to listen to those signals, and do what your body is comfortable with and tolerates. So if you find that it's too hard and there's too much pain, then I would recommend scaling back. And there's no hard and fast rule. For the strength, I'm not sure if you're referring to 3 times a week strength training or aerobic exercise, but for the strength training, it doesn't need to be 3 times a week. It can be twice a week as well. And if twice a week is, it can be lighter exercise. Remember, it's dose dependent, and any amount could reasonably be felt to be beneficial.
Great, thank you. Question regarding, well, in ducts, in FSHD, the dystrophic muscles become fat, infiltrated. Supposing that there is a therapy to try to address DUX4 toxicity, do you believe that it may be possible to restore some function in those dystrophic muscles if you can stop the degenerative process?
That's a wonderful question, like all the other questions. Well, I mean, wouldn't it be amazing to reduce the DUX4 toxicity, and whether this could reverse muscle weakness and fatty replacement is unknown to me. I don't know. It might also be a little tricky to measure, because when you have a progressive condition, it can be hard to measure a deceleration of progression. So basically improvement may be hard, but what you may have is deceleration of progression, on such a medication, which is also tricky to measure. So good question. It's possible. I don't know.
Yeah. I think about that often too, and I think it must depend on whether an individual muscle retains some kind of regenerative capacity, like enough satellite cells, versus a muscle that may have lost or burned out, essentially. So I don't know if that makes sense just from my what I've looked at in the biology. But all right, here's a question. Do you know if the MDA or other agencies, I suppose, supply financing or for home modifications? That's a big question.
So my understanding is that in certain occasions that is available. I haven't, on the other hand, I haven't seen that happen a lot. And now, so I haven't seen it happen a lot. And also, so I would ask, I would make a case for it. I'm sure the clinic will try to advocate for it. But I don't know that it will happen for sure. But on their website, and as you saw a reference, I did reference an MDA website, which had information about exercise and which had information about home adaptations and modifications. They did mention that. They do mention that as part of their official literature. So in theory, it's available. It might be tricky, but I would ask.
Great, okay. I think my understanding too is a lot of states, the Department of Rehabilitation, I think it is, will help fund renovations or adaptations that are required for somebody to be able to continue working. So they have a big interest in enabling people to keep working or find new employment, and that there's financial resources for that. But I also understand there's often a lot of bureaucracy that takes a tremendous amount of patience and persistence to access that kind of aid. But and that's a topic, we will need to explore further sometime in the future. Here's a question whether she noticed in the photo of the bathroom, and I think this person might have the same issue at home, electrical outlets are often located kind of out of reach, like there might be across a counter and you might have difficulty reaching. Are there any adaptations that could help make electrical outlets more accessible?
You know, that's a great question. That's not something I've come across. I mean, extension cords come to mind, but I'm just kind of, you know, this is just me thinking off the top of my head. Maybe Juliana, maybe you have, you've come across this, or anybody else in our audience that has ideas, they can share them on the chat.
Yeah, that would be great. Yeah, I thought about extension cords too, but I think in certain settings like a bathroom or kitchen, that could be dangerous, right?
Exactly. Yeah. I mean, yeah.
Let's see. What recommendations do you have if someone with FSHD experiences a soft tissue injury such as whiplash? You know, and how to communicate with health professionals who might not have knowledge about FSHD? What kinds of tests should be done and prior to commencing treatment for, I guess, soft tissue injuries?
Yeah, so whiplash is a tough condition because it can, you know, after a neck injury, it can lead to chronic pain, and that can be, you know, in patients with FSH and certainly, you know, in patients without FSH. So, you know, I don't know of anything specific to FSHD that would sort of influence how one might experience whiplash. I mean, if there's a degree of, a significant degree of weakness, and also FSHD can affect axial muscles, like core muscles. So there's like a theoretic, you know, possible like increased risk to some of the hyper extension that happens, you know, with the whiplash. You know, the treatments, I would say, are the same that they are in patients without FSHD for whiplash. And those are, you know, there's some medications like tricyclic antidepressants, there's rest, there's physical therapy, you know, there's heat. So I don't know that those are any different in patients with FSHD. And in terms of talking to providers that may have limited experience with FSHD, I mean, if you know, this isn't, you know, this is a time where there's increased, you know, genetic diagnosis of more conditions that at other times may have not been diagnosed. So I think that people may be more open to it, but if you want to get more specific, you know, and get more time to discuss those, maybe seeing a neurologist or a neuromuscular specialist, who would certainly neuromuscular specialist would be very much focused on the FSH aspect of your care. The other thing that I would say is that, you know, if you have FSH that is impacting you in very specific ways that that impact your routine interactions with providers, you could also have records with you and just say, hey, you know, these are my records from my neuromuscular physician, and you know, this is the big picture, and just be able to hand it over to people that are seeing you. You know, 1-page summary, and then, you know, they'll read it, no doubt.
Great, thank you. Question here about massage therapy. What are your thoughts about that, and whether, and also there are different types, very deep tissue versus more less deep massage?
You know, I don't know much about that at all. So massages in general, I just don't know much about them, and then the different types of massages either. I would say that if you perceive them as helpful, and they help, you know, they help you feel better, they help you function better, then I would certainly have them as part of the mix of supportive therapies. But just make sure that, you know, they're helping you. If there's pain and discomfort, you know, I don't think it's a no pain, no gain situation. I think if they help you, you can do it. If they don't help, I wouldn't do it.
Okay, fair enough. A question here about, I guess, do you know about, I guess it's called electrical stimulus apparatus? I think, is it there's a device that I think probably makes your muscles twitch
Yeah,
by stimulating the nerve.
yeah,
Are you familiar with
yeah,
that?
yeah. There's a number of devices that are used more in like the physical therapy world. Um, and, to my knowledge, there's no evidence that they are, like effective. Otherwise, we'd be talking about them, a lot more. So I would be cautious in using those because there's limited evidence, and also if they're expensive and they're sort of commercially provided and they're expensive, then I would be extremely cautious.
Okay. Okay, great, thanks. Here's a question about the use of antioxidants and anti-inflammatory, maybe food supplements and so on, vitamins, antioxidant-rich berries, turmeric, etc.
So, I think a healthy diet that doesn't have oxidating foods, or that has healthy fats that have like olive oil, like a Mediterranean diet, lots of fish, that have antioxidative properties, that have good fats. I think that's a really key part of a healthy lifestyle and an excellent complement to exercise and optimizing your function. Now, specifically about supplements, there's been very scant evidence compared to, say, the Mediterranean diet, where there is evidence that it's very positive for health outcomes. So I would focus more on a healthy diet and invest the time, because and the resources on diet as opposed to supplements. And I haven't seen anything in the FSHD, and I'll say that. So I would invest on the diet, quality of diet, and time, more so than the supplements, is what I would say.
Okay, great, thank you. Maybe here's one last question. Has fatigue in FSHD patients been studied in terms of the cause, whether it's due to exertion, muscle weakness, postural changes, etc.?
That's a great question. My understanding there is that, we see increased fatigue in a number of neuromuscular diseases, not just FSHD. So, fatigue has been studied in FSHD, but we see it in myasthenia gravis. We see it, in other myopathies like limb-girdle muscular dystrophies. We see it in myotonic dystrophy type 1. So my thinking is that it's probably, there's a degree of, it's probably multifactorial. That's my thinking on it. But, so basically there's the muscle disease. There may be sleep quality issues. There may be mental health. There may be a mental health component as well. So I would say multifactorial, but that's really the most I can say.
Okay, wonderful. Thank you so much. Well, we're at the end of the hour. I'm going to bring Beth back, but one final comment is there have been some requests to see some of the slides that you showed, and I wanted to tell our audience, we will be posting the recording. It's available on Facebook Live right now, and we'll be also posting it on YouTube. So you can go back and look at it and find the web addresses and images that you want to see. Again, they'll be right there. And a quick commercial, a lot of commentary about bathroom design. That triggered a lot of, everybody has strong opinions about that. I think it's a very challenging room to design. And at the upcoming FSHD Connect Classroom conference, we will have an architect who specializes in universal design who will be talking about that. So with that little advertorial, I'll turn it over to Beth.
Yes, be sure to sign up for FSHD Connect. We have a lot of good topics that we'll cover on 27th of June. Be there or be square. So thank you for attending our Sequester Camp webinar today, and a very, very special thank you to Dr. Farmakidis for all of this excellent information and really for taking the time to be with us today.
Thanks for having me. I really appreciated joining you. Thank you very much.
Awesome. Like June said, we'll be updating our Sequester Camp webpage with this video recording when once it is produced, and with other information as it arises. So check back to the website, Facebook page, as well as our YouTube channel for all of this, for this video recording, as well as all the other ones that have been produced. On next Thursday's webinar, we've got another very special guest, Dr. Rita Perlingiro from the University of Minnesota, who's going to be speaking about stem cell research in FSHD. And then, of course, Bill and Mitch will be back this coming Monday afternoon at 3 Eastern, broadcasting their fitness workouts, and they'll continue to do that on Mondays through June the 22nd. Wednesday evenings at 9 p.m., catch our radio show guy, Tim Hollenbach, on Facebook Live. And then on Wednesday afternoons, Belinda Miller is reading her children's book on Facebook Live as well. So keep an eye out here for email updates that will be coming out every week, announcing upcoming events. And we will see you guys again here next week. So take care, everyone, and we'll see you soon. Again, thank you again, Dr. Farmakidis. Much appreciated.
Sure, my pleasure. Thank you so much. Bye now.
Take care, everybody.